Hello, everybody. So before we begin the presentation, I would like to introduce you to a guest of mine. Now, this is a giant version of Chagas, and this will be my guest for the speech today, which will be on Chagas. What a surprise. My name is Alex Mold, and I will be giving this talk. So we're going to start off with the background of what it is. We'll get into the treatment. We'll get into how it was diagnosed and all of the other factors surrounding Chagas. So to begin with, this is Chagas on the right. You can actually see it. It is a unicellular protozoa, so it is more closely related to animals than it is to anything else. It is named after James Chagas. We'll talk about what he did in the next slide, but he was the first person to discover it. It affects between 6 and 7 million people worldwide, and it's traditionally found in Central and South America. But in recent years, it has been expanding into North America, Europe, and the Pacific. Now, this is due to a number of factors, and we will touch on all of those momentarily. So the history. So it was first discovered in railroad workers in Brazil. This was an outbreak of a bizarre fever and a lymphadenopathy. So what he did was he took blood samples from all of the people, and he discovered the protozoa that we saw in the previous slide. But he was only the first person to discover it. This was not the first outbreak. From archaeological studies, it likely crossed over into Chilean and Peruvian populations somewhere around 9,000 years ago. And this was done through mummies that were found in the area, where about 283 of the found mummies between 7500 BC and roughly 1400 before Cortez came, they found in some of those mummies a soft tissue change that's associated with Chagas, of which 41 ended up testing positive for actual Chagas through PCR amplification, which means that this is a very old disease in human population. And somewhere around 300 years ago, with the introduction of domestic animals, that's likely when it crossed over into horses, cows, pigs, sheep, and others that it now considers its host. At the time that these mummies were around, it was in about 20% of the population. Now, in the current range, it's between 20 and 80%, depending on a number of factors. But what this tells us is that that's likely in the right ballpark of what it used to be. So it's very much an endemic disease. So the transmission. So this is from a kissing bug. The next slide will have a picture of it. And it is a fecal-oral route from the bug. So first, the kissing bug bites you. And when it bites you, it will pick up the zygotes, and those zygotes then undergo maturation in the gut of the kissing bug, and they multiply, and then they go out through the feces. So when the kissing bug bites you, it deposits fecal material into the wound, and then that fecal material contains the zygotes. It goes into the cells, and then they constantly grow and develop, and you actually diagnosed in the zygotic stage, and that is the previous image. You can also get it from blood that's improperly treated. There has been documented cases of vertical transmission. However, aside from anemia, there's no other birth defects associated specifically with it. You can also rarely get it from sugarcane juice, especially if the kissing bug has been found in it. Because again, that's a great food source for them and they enjoy it. So this is the kissing bug. It's roughly a finger-sized bug with very, very obvious orange or red markings across its abdomen and thorax. And this is the part that bites you. So these things love to live near humans. They love to live in the cracks, in the roofs, in the walls, and they especially love thatched roofs because that's where they breed. They come out at night to feed, so when everybody is asleep. They also like to feed on livestock and dogs are actually, after humans, one of the most affected species with T. cruzi. As such, they are also an important part of the public health aspect. And we'll talk more as we get through about ways to actually prevent this. So the symptoms. So the first phase is about 5 to 40 days after the initial infection, and it occurs in about 10 to 30% of people. So this is the fever, malaise, and lymphadenopathy near the site of the bite that was determined by Mr. Chagas all those years ago. But there's also some abdominal pain and anorexia that might occur, and again, a rash in the area. Usually, this is non-fatal and people go on to live. However, in about 5 to 10% of people, usually children, myocarditis and meningoencephalitis can occur. Myocarditis is an inflammation of the heart, and meningoencephalitis is an infection of both the meninges and the brain. However, for the majority of people, you end up with a chronic infection, and that is usually asymptomatic. However, in about 30 to 40% of those, they develop complications, most notably dilated cardiomyopathy and a megacolon and a megaesophagus. The latter of which, the megaesophagus, is more prominent in dogs, but it can occur in humans. However, it is unlikely. And this is actually a result of some of the actual neurological damage. So once it's damaged, it can't actually be repaired because all of the neurological centers that are associated with constricting it have been killed off. So it will just expand until it can't expand anymore. So the diagnosis. Blood antibodies are one of the easiest ways to do it. It has a very high specificity and a very high sensitivity. This is a great screening tool, and it's also pretty accurate. Additionally, PCR amplification is very specific because it will only grow Trypanosoma cruzi, but it's not very sensitive because the PCR markers are not always guaranteed to bind to the actual DNA because this can mutate. And of course, you can do direct microscopy, and that is the cheapest and the easiest one to perform, but you do need a high parasite count in order to detect it, and you need somebody who's trained in looking at it. As you can see here, these are two of the complications. The third one, megaesophagus, looks remarkably similar, but it is not shown. However, it does occur in dogs. So here on the left image, you can see the megaesophagus, or the megacolon, as it is massively blown. And on the right, in the X-ray, you can see that the heart is almost half the size of the chest, and that is way too big for the average person. And in this EKG, which is probably the way that they would initially diagnose it, you can actually see how massive this heart is, as it is very, very elongated in all directions. And these are all complications as a result of chronic Chagas disease. So the high-risk groups. So this is the people who usually get it. Living in Central and South America, it's been there forever, and it will keep being there. So that's a very big risk group. And the people that usually get it are in the poor housing, as I've mentioned before. So this is very much associated as a disease of poverty, which means that people who live in thatch roof houses or walls with many cracks in it, they love to live there. And it usually occurs at the edge of deforestation. So when we damage the environment that the kissing bug lives in, what ends up happening is that they go to the next nearest place, which tends to be thatch roofs. As such, the amount of bugs in proximity to humans increases, so the risk increases. Additionally, when we're talking about migration, Trypanosoma cruzi is only in those regions traditionally, but the kissing bug actually has a range all the way up through most of the United States and parts of southern Canada. So even though it's not in the US, because of the increased migration across the border, it's a potential to get there as well. Additionally, it can go to Europe and it can go to the Pacific because of the migration out of Central and South America. So the habitat for these animals is actually very important. So the management, luckily, it's only a drug. So benzonazidil and nifurtimox. So these are both free radical generators that help in the destruction of Trypanosoma cruzi in an aerobic environment. They're great because they are relatively inexpensive and they can treat it. They can only treat T. cruzi. They cannot treat anything of the complications. You can also do the improvement of housing because this will reduce the ability of the kissing bug to breed in the house. Additionally, decreasing deforestation will reduce the amount of exposure at the forest edge to humans to the kissing bug. And this will also have the added benefit of reducing animal cases as well. Unfortunately, in this case, as there's such a massive animal reservoir, you are unlikely to have a reduction of a complete elimination of the disease. Additionally, screening of the asymptomatic people will result in reduced risk of complications as it is caught early. So with that, I conclude my presentation. If you have any questions, you are free to reach out to me in any way. Thank you for your time, and here is my bibliography of all sources that I use. And I'd also like to thank my guest for this. Thank you, and have a good day.